Hello again, everybody. We're going to talk here about bilious vomiting in the infant, particularly in the neonate, which you'll see a lot of these in. So I divide the pediatric surgery section up into 4 bite-sized pieces. Now, not all of the problems that are discussed in each of these categories are restricted to each of these categories. Some may occur in both. For instance, we'll talk about malrotation. Malrotation can be an infancy problem, a problem in the neonate, and it can also cause bilious vomiting. So, but I wanted to kind of divide these up, especially so you can make your differential. So you have problems in the neonate, you've got problems that present often as bilious vomiting, problems in primarily the infant, the older infant, and the problems that can be into later childhood. Okay, so this is going to be what we're going to talk about. We've got 7 things, so let's get started. Duodenal atresia is a congenital absence or a complete closure of part of the duodenal lumen. This is a defect that occurs early on in embryonic stages, and it happens typically because of genetic issues. So it's often associated with Down syndrome, can also be associated with cardiac lesions as well as the Vactérel sequence. Oftentimes you can note duodenal atresia on ultrasound, and you get you don't necessarily know if you can see the duodenal atresia on ultrasound, but what you can note is the polyhydramnios that's associated with duodenal atresia in fetal life. Why would you get polyhydramnios, excess amniotic fluid? Remember what the baby is supposed to do when it's in the womb. It's supposed to swallow a certain amount of amniotic fluid, and it's supposed to pee out a certain amount of amniotic fluid. What are some things that would prevent the baby from swallowing amniotic fluid? Well, of course, anything that obstructs the GI tract. So things such as esophageal atresia, duodenal atresia, etc. So if you have duodenal atresia, you can't swallow enough of the amniotic fluid. It'll either be spit back out, regurgitated, etc., or just not swallowed. And so you'll accumulate excess amniotic fluid, and that causes polyhydramnios, which in the OB patient would be noted as that she's larger for gestational her gestational period. Now, on the other hand, while we're on that note, oligohydramnios, which is not enough amniotic fluid, that's caused oftentimes because the baby can't pee out fluid, which is supposed to go into the amniotic fluid, into that mixture. And so things such as renal agenesis, that can cause oligohydramnios because the baby's not urinating. With polyhydramnios and oligohydramnios, it's usually not a problem with the woman, it's usually a problem with the fetus, inside the fetus. The symptoms of duodenal atresia most notably are bilious vomiting, and this typically happens within hours after birth. You may see failure to pass meconium, but typically the bilious vomiting comes up first, and so we're already thinking duodenal atresia before we're worried about the fact that the baby hasn't passed meconium. A lot of times the baby can pass meconium, and the reason is because there's usually meconium distal to the atresia, and so that can pass. You can also see a distended abdomen, but keep in mind that with duodenal atresia, the blockage is very proximal relative to the rest of the GI tract, and so distal to the blockage, there's not really not going to be any gas or any material, and so you're not the only area that's really going to be distended is the stomach and the duodenum. And so you're not going to see as distended of an abdomen as you may see in a more distal blockage, such as jejunal or ileal atresia or colonic atresia. But distended abdomen is worth noting in the symptoms. For diagnosis, the best initial diagnostic step when you suspect duodenal atresia, which you always should if there's bilious vomiting, is to get an X-ray. That's going to be your best first step. And the X-ray, you're looking at the abdomen, but I mean, you won't necessarily order an abdominal X-ray per se because the baby is usually smaller than the X-ray plate, so you're really just getting an X-ray of the whole baby. A lot of times they call that a babygram, but I don't think that's going to come up as the answer choice. It'll probably just say X-ray. So you're getting an X-ray looking at the abdomen, and Classically, in duodenal atresia, you'll see the double bubble sign, which is two distended lumens, the stomach and the duodenum. Remember, you have a sphincter in between the two, so that's why you've got two distinct lumens. And you'll see an air fluid level in those lumens. And so, because you have two, it's called a double bubble sign. So double bubble is a kind of gum that you can buy in the US. And I don't know, maybe that's where they got the name for one or the other. Who knows what came first? Okay, so here's your double bubble sign. Stomach here on the left, duodenum here on the right. Double bubble sign. You see this in conjunction with bilious vomiting, you pretty much have your diagnosis. Everything distal to that, there's really nothing, because you have a blockage, and so there's not going to be any air or gas or material distal to your blockage. Here's another one, a little less distinct than the previous. And this is an MRI of the woman before she gave birth. And you're not going to get an MRI to diagnose duodenal atresia before a woman gives birth necessarily. You have to ask an OB on that one. But what I wanted to point out is that you can see the duodenal atresia even before the baby's born. This happens much, much earlier than birth. So you can see the double bubble. I just thought it was a cool picture. So it's an MRI. You can see bladder here as well, and lungs. Okay, so what do we do for treatment? We need to surgically correct this because this is an atretic bowel, and so we need to work around it. And typically, the procedure that the surgeon prefers is a duodenostomy, where you're creating a new lumen in between where the from normal bowel to normal bowel. So you're working around it. This is not an emergent surgery because duodenal atresia is not in and of itself life-threatening. Typically, though, if you defer it, you'll only defer it maybe 24 or 48 hours. But if you defer surgery for duodenal atresia, what you need to do is rule out malrotation. And as we're going to see later on when we talk about malrotation can present the exact same way as duodenal atresia if it's early enough. You'll do an x-ray, and you'll have bilious vomiting, you'll get an x-ray, you'll see a double bubble sign, and that can be malrotation or it can be duodenal atresia. So what you have to do in a patient with a double bubble sign, if you're going to defer the surgery, is to make sure it's not malrotation. So what you'll get is a contrast enema and an upper GI contrast series, and that's going to help you distinguish for sure whether this is duodenal atresia or malrotation. Now, on the other hand, if you're going to just go in and do the surgery right away, you don't need to necessarily distinguish the two because you're just going to correct it surgically. Before operation, you'll do an NG decompression, just to decompress anything that's in the stomach and duodenum, and then you'll have the baby on IV fluids and nutrition because there'll be NPO. After the operation, you'll observe the baby and continue parenteral nutrition. You're not going to start oral feeds right away. The reason is because we need that new ostomy, that duodenostomy, our new lumen. We need that suture area to heal. And once that's healed, then we can start oral nutrition. And usually parenteral nutrition is continued until the first stool is passed. We'll also have the baby on prophylactic antibiotics because that suture line is at risk for infection. So we want to prevent that from happening too. So these are just preventing complications. An annular pancreas can present also identical to duodenal atresia. What an annular pancreas is it's a blockage of the duodenum because of this ring of pancreatic tissue that's compressing the duodenum. So if you think of it pathologically, or not pathologically, but pathophysiologically, it's really the same thing. You have a blockage of the duodenum in roughly the same area. You're going to get bilious vomiting. You're going to get abdominal distension. And you're going to see the double bubble sign because you have blockage of the duodenum. So you have a dilated stomach, dilated duodenum. But rather than an atretic duodenum, here you have an external compression of a ring of external pancreatic tissue that's compressing the duodenum. So this is rarer, and it's less associated with congenital problems compared to duodenal atresia, but this presents a different problem. So it's worth noting this on the side. The treatment, though, is the same. You're going to create a new lumen. You're taking one part of the duodenum and attaching it to another part of the duodenum, so you're kind of working around that blockage. What you're not doing, and this is why I bring up annular pancreas, is you're not going to cut that pancreas. That can actually kill the baby. So you're still going to do the same surgery you're going to do with duodenal atresia, because you can't cut through that pancreas. That is absolutely contraindicated. Don't do it. So know that you don't do that. You're just going to do the exact same surgery you do for duodenal atresia. You connect part of the duodenum to another part of the duodenum, and you're creating a new lumen that way. Okay? So intestinal atresia includes jejunal and ileal atresia and colonic atresia, and these are different from duodenal atresia for a couple reasons. One, they're in different places, and so they're going to look different on X-ray. Two, these are caused typically not by genetic anomalies, but they're caused by vascular accidents in utero. And so therefore, they're less associated with congenital conditions like Down syndrome, Beckwith-Wiedemann syndrome, etc. However, there has been a study that has shown that 10% of non-duodenal atresias do have cystic fibrosis. The symptoms of intestinal atresia are basically the same as duodenal atresia, because what you have a blockage in the intestines, and so therefore eventually you're going to get vomiting because the baby's feeding and there's nowhere for that to go, and eventually the baby will vomit it up. You can have noted failure to pass meconium, but just like the same reasons that you may not see that in duodenal atresia, you may not see that in intestinal atresia, because there can be meconium distal. And then abdominal distension. And usually with jejunal and ileal atresia and colonic atresia, the distension is worse than with duodenal atresia, because there's much more space for gas to go, for contents to go in the bowel. You're not just limited to your stomach and duodenum. It can be in the ileum, and the jejunum, and the large bowel, and so forth. So the severity of distension tends to be proportional to how far the obstruction is down the GI tract. For diagnosis, exact same way that you did for duodenal atresia, you're going to get an X-ray, and that X-ray is going to help you, it'll definitely help you distinguish further intestinal atresia from duodenal atresia. However, the X-ray is not the end-all. The X-ray can't tell you for sure where the blockage is. So further diagnostic workup can be aided with a contrast enema or an upper GI series. So here's an example of what I mean, that they look different. So remember, with duodenal atresia, you see the double bubble. You see the stomach, which is separated by a sphincter from the duodenum, and they're both dilated because you have a blockage distal to the duodenum. With jejunal atresia, you also have a dilated jejunum, and so you see three bubbles a lot of times. Not always, but this is a classic radiologic appearance of jejunal atresia. A lot of radiologists will call this the triple bubble sign. With ileal and colonic atresia, because the ileum and because the ileum is so long, and the jejunum as well, you'll see a lot of times what just look like loops of small bowel, and so you can see that here. It's not so much 2 or 3 distinct lumens. You see a lot of loops of bowel. And colonic atresia looks similar to ileal atresia. However, a skilled radiologist will be able to tell you a lot of times if this is probably dilated large bowel versus dilated small bowel. On the USMLE, you won't be expected to know the difference between that. The reason is because if you radiologically suspect ileal atresia or colonic atresia, you need to get a contrast enema. And that contrast enema is going to help you distinguish whether it's ileal atresia or colonic atresia. With ileal atresia, you'll be able to visualize the entire small bowel. With colonic atresia, there'll be a blockage. Okay, so what do we do for treatment? The treatment is corrective surgery, just like duodenal atresia. And the exact procedure is going to be based on the surgeon's preference. So all you need to know, excuse me, is that it requires surgery. And it's similar pre- and post-op management as we did in duodenal atresia. So here's jejunal atresia. You can kind of see 3 bubbles here. Definitely not 2. Here again you have kind of 3. Another one. This is ileal atresia. You can see loops of bowel here. There's more loops. And this is colonic atresia. And actually, you can see that there's been a contrast enema done here, and there's a blockage. So, when you do that contrast enema, this is going to help you distinguish ileal from colonic atresia. But a lot of times you're going to do the contrast enema in any kind of suspected atresia patient. So the contrast enema will help you visualize the large bowel. And what you note with any kind of atresia, except for colonic atresia, is a microcolon. And the reason you have a microcolon is because you're not using your large bowel. You have a blockage that's in the small bowel, and so you have nothing getting down into the large bowel. A microcolon technically is a large bowel that's no greater than 1 centimeter in caliber. And so this is a microcolon. This is another microcolon here. Baby's kind of situated differently, so it looks a little different. Now this is colonic atresia. You see parts of the bowel that are normal and parts that are atretic, like right here and right here. Okay. So that's colonic atresia. It's different. It's not a confluent microcolon. It's parts are atretic and then parts are normal. All right, so enough about atresia. Let's talk about something different, malrotation. So malrotation is a surgical emergency once you diagnose it, and what it is an abnormal or incomplete rotation of the bowel during during fetal development. And during fetal development, what normally happens is you have development of the bowel outside of the fetus, and then that bowel rotates and comes into the fetus, and eventually it closes up. During malrotation, what happens is that process does not occur properly. You don't get proper rotation, and therefore the small and large bowel are not going to be in their normal anatomic position. So what happens is that the cecum, rather than entering the right lower quadrant, is usually stuck up in the right upper quadrant. The base of the small bowel is, rather than being fixed on the ligament of Treitz, is fixed solely on the superior mesenteric artery. And then you get these bands, and these Ladd's bands, what they're called, they're supposed to attach the cecum to in the right lower quadrant to the abdominal wall, but rather than doing that, they attach the cecum to either other organs or the abdominal wall, but they cover small bowel, and that can cause intestinal obstruction. And so these Ladd's bands are normal, but with malrotation, they're not in the normal place, and so they can cause problems. 70 to 90% of malrotation cases are diagnosed within the first year of life, but it can be diagnosed after that in some cases if it doesn't cause a problem early on enough. The major problems with malrotation are intestinal obstruction, and typically that's due to the Ladd's bands. You can also get midgut volvulus, and this is a very big, deadly problem. And so this is where you get volvulus because the malrotated bowel is much more mobile, and because it's only it's only attached, it's only fixed on the superior mesenteric artery. And so when you get volvulus, it's actually going to cut off flow from the superior mesenteric artery. And when you cut off flow to the superior mesenteric artery, you're cutting off flow to almost pretty much all your small bowel and even parts of your large bowel. So that's a big, big, big problem. And so this results in ischemia, necrosis, gangrene, perforation, etc., and that will cause death eventually. So midgut volvulus is the thing that causes death in babies with malrotation. So the symptoms of malrotation include bilious vomiting, bloating, distension. That can all be from obstruction. If you get volvulus, eventually you're going to have inflammation, ischemia, necrosis, etc. So that's going to cause fever, nausea, vomiting, blood-streaked stools, or melena. So malrotation, depending on whether or not there's obstruction or midgut volvulus, and in that case, whether or not there's ischemia and necrosis, that's going to change the presentation. So not all babies with malrotation necessarily will present in the same way. Some will present with obstruction. That can look just like your duodenal atresia. And remember, that's why we had to get, if you're not going to do surgery right away, that's why you need to rule out malrotation. Whereas some can present with volvulus, and that's going to be a lot more of an alarming presentation. So the symptoms depend on whether or not there's obstruction or volvulus. So for diagnosis, if you suspect malrotation, in addition to getting the x-ray, and usually if the baby is stable and they're just having bilious, vomiting, bloating, distension, usually you're suspecting duodenal atresia. And so because the baby's stable, you're going to get an x-ray. And a lot of times, usually this shows the double bubble sign, but in contrast to duodenal atresia, sometimes with malrotation, you'll see these distal air fluid levels, and those are alarming because it shows that this is probably not atresia because there is some air, there's some gas in the distal bowel. And so that suggests malrotation, but you don't always see that. So the double bubble sign, if there's air fluid levels present, that points you towards malrotation. Either way, no matter what, this has to be followed up with an upper GI contrast series or a contrast enema, which are critical for diagnosis. If the baby's not stable, you're just going to get a contrast enema. The upper GI contrast series takes longer. So this is going to help you diagnose malrotation, distinguish it from an atresia. Usually, though, I would just keep it in the back of your mind. If this is a baby that is 2 months old, it's not going to be atresia, because remember, atresia presents right away. But if it's a neonate, it might be atresia. So when you're making your differential, keep these things in mind. Okay, so when we do imaging in malrotation, these are some principles to remember. If the patient has intestinal obstruction but no midgut volvulus, then the common finding is to see, when you do your upper GI contrast series, what you're going to see is a dilated bowel, and you'll only see contrast on the right side. So if the baby doesn't have midgut volvulus, they're typically stable, so you'll have time to do your upper GI series. And so what you'll see is just bowel on the right side when you do your contrast series. If the patient has an intestinal obstruction and they have midgut volvulus, if you do your contrast enema, a lot of times what you'll see is if it gets, since we're on the upper GI series, you'll see a corkscrew or a beak-like appearance, and distal to that there's going to be scant contrast because you have a volvulus, so none of the contrast is going distal to that. Okay, so here's what I mean. So here's your upper GI contrast enema. You see primarily contrast on the right as opposed to on the left. Okay, here's another one. On the right, but not so much on the left. This is just a product of that volvulus. Most of your bowel is on the right. Okay, so here is a midgut volvulus. So you see this twisting and this corkscrew-like appearance. Here's another one. The twisting is right here. Right here. So this is your corkscrew-like appearance. Here's another one. This looks more like a beak. You almost see it looks like a bird here. All right, so here's your twisting. What do we do for treatment? The treatment is emergent surgical correction, and this is called Ladd's procedure. In addition to surgical correction, you'll resect the dead bowel. So what you do during Lat's procedure is you mobilize the bowel, untwist it. You'll divide the Lad's bands, and you'll widen the mesenteric base to prevent this from happening again. Typically, you won't be able to get all the bowel into its normal anatomic position, but that's not necessarily what's important. What's most important is that you mobilize the bowel and cut the Lad's bands. You'll also want to look for any dead bowel that's there. If you see any bowel that looks like it might be on the border of dead, you can close the baby up as long as they're stable, and then take a second look in 24 to 48 hours. You may even do a second look if you don't see anything that looks dead. So a lot of times what happens if you have necrosis or if you have ischemia, the bowel may survive or it might not, and you can't really tell, and you don't want to cut out bowel if you don't have to, and so you'll sew the baby back up, and then in 24 to 48 hours you'll look again, and if the bowel looks fine after 24 to 48 hours, you can leave it there. If it looks angry, you take it out. So malrotation, remember that this is an emergency. Remember the complications can be obstruction or midgut volvulus, which is an extreme emergency. Remember that you need to do your either upper GI contrast series or contrast enema. Upper GI contrast series, though, is only if the baby's stable. These are critical for diagnosis. And the treatment is emergent surgical correction. And also remember the symptoms. They can look like atresia, but usually these are going to be babies that are more than a day or two old. And if there's volvulus, then you'll have the fever, nausea, vomiting, blood streak, stools, etc. Okay, necrotizing enterocolitis. So this is a disease of unclear etiology, and likely what it is due to is a hypoxic insult to bowel, or here we're talking large bowel, especially in a premature infant. Actually, it could be small bowel too, especially in a premature infant. So what they think is that the baby, since they're premature, they don't have a properly developed immune system yet. And normally there's bacteria in the bowel, but what happens is if you get these normal hypoxic events that happen every so often, you get the normal sloughing that happens, but you get bacterial invasion. Normally your immune system would be able to take care of that, but because these babies are premature, they can't take care of that normal bacterial invasion, and so the bacteria will actually colonize and then inflame the bowel and cause gangrene perforation. So that's what the theory is, but this is really an unclear etiology. What we do know, though, is that there's a preponderance of NEC in premature infants. The symptoms of necrotizing enterocolitis are intolerance to feeds, abdominal distension, notably bloody stools, vomiting, diarrhea on physical exam. You'll note decreased bowel sounds. If it's severe enough, you may even note erythema over the abdomen, which suggests peritonitis, and shock. Initial labs will be useful in helping you with this diagnosis. Classically, CBC will show thrombocytopenia, abnormal white count. It may be abnormally low or abnormally high, and a low hematocrit. Your electrolytes typically show a hyponatremia and a metabolic acidosis. So for diagnosis, the best initial step is an abdominal x-ray. Abdominal x-ray is the mainstay for diagnosing NEC, and the reason is because it gives your classic signs that are very specific to NEC. And these are dilated bowel, edematous walls, and intramural air. So when you have an infection of the bowel, what can happen is the bacteria will colonize inside the tissue, and when you get bacteria colonizing inside the tissue, they secrete gas, and that gas will separate the tissues, the tissues of the lumen, and so you have air in between the tissues of the small intestine. So be observant for signs of bowel perforation, which would include air in the mediastinum, in the peritoneum. I knew I said something wrong there. If there's pneumoperitoneum, then you need to do emergent surgery because that's a sign of perforation. So when you get these x-rays, you'll want to obtain these in AP view and a left lateral decubitus view because that will help you see if there's any air in the peritoneum. All right, so this is necrotizing enterocolitis. What you see here is air in between the tissues, and you really have to look closely, but you see air in between the tissues of the bowel. Right here, here's another good view. You see that line of air in between the tissues, that lucent line there. So here's another one. Look really closely here. You'll see this line of air here distinguished by this white line. You can also, and you might not be able to see it on YouTube because it doesn't give you as good of a resolution, but you can also get air into the biliary tract as well. And that you can see it kind of gives the liver a speckled appearance. Again here, you see this lucent circular line here. That's air in between the tissues of the small bowel. Okay, what do we do here? So for treatment, you would think that you're going to go straight in for surgery, but no, this is actually medical treatment unless you have perforation. So provided that there's no signs of perforation, the primary treatment is medical. We're going to decompress the baby with an NG tube, provide broad-spectrum IV antibiotics to prevent from sepsis, and provide the baby with IV fluids and nutrition. We're going to follow the baby in the NICU with serial abdominal x-rays to make sure there's no perforation, and then monitor the metabolic parameters such as acidemia, apnea, and body temperature. Surgery is reserved for perforation. Other things that may cause a pediatric surgeon to do surgery would be worsening signs of peritonitis and failure to stabilize within 12 hours. The reason we want to avoid surgery is because there's a decreased survival in patients who require surgery. 80% of patients who don't do surgery survive, 50% who require surgery survive. Okay, meconium ileus. This is an impaction of meconium, which is overly thick and tenacious, and it's in the distal small bowel. So meconium ileus typically comes up in cystic fibrosis. Remember what cystic fibrosis is. It's a defect of a chloride channel, and that's going to cause a defect of fluid secretion. And so the meconium is going to be thick. Just like when you have a cystic fibrosis patient, their lung secretions are thick. And so what you have here is meconium that's thick and it can't get through the baby, and so it compacts. So the symptoms here are abdominal distension because you have blockage, bilious vomiting, again because of blockage, failure to pass meconium. So here you're going to have a true failure to pass meconium because the meconium has blocked the GI tract, and that meconium is too thick to go anywhere. Respiratory complications can develop if there's severe enough abdominal distension. A lot of times you do see severe abdominal distension here. The best initial diagnostic test, again, is an abdominal x-ray, which also will show multiple loops of small bowel with, in this case, a soap bubble appearance, but that's not specific to meconium ileus. What you're going to be trying to differentiate meconium ileus from is Ileal Atresia. They look very similar. And so because of that, what you'll want to get is an upper GI contrast study and a contrast enema, and that's going to help you differentiate this from Ileal Atresia. So for treatment, typically this is done during the diagnostic enema. So if you suspect meconium ileus, you're going to add N-acetylcysteine into the contrast fluid, and what that does is it dissolves the meconium, and that usually will unblock the blockage. If that's unsuccessful, laparotomy will be required, and then of course remember to get a cystic fibrosis test too, because meconium ileus is cystic fibrosis until proven otherwise. So what do we see on the contrast? Well, okay, what do we see first off on the x-ray? Well, it looks pretty similar to Ileal Atresia in that you've got these multiple loops of small bowel. A lot of times though, when they say that soap bubble appearance, you've got this like ground glass appearance in the small bowel. So it's kind of hard to tell, but with ileal atresia, it's a little bit more lucent in the small bowel than with Meconium ileus. So when you do the contrast enema, this is really going to help you with making your diagnosis of Meconium ileus. You'll see insipated packings of meconium, and they appear as these lucent areas in your contrast enema. So this is meconium here, and this really helps you distinguish this from ileal atresia. Note again here you have a microcolon because you've got blockage, so you're not using your colon as much. So again here, microcolon, and you've got these insipated pieces of meconium. Okay, so finally, meconium plug syndrome. So this is not the same as Meconium ileus. In Meconium ileus, the meconium is the problem. It's abnormally thick, but the intestine itself is normal. With Meconium plug syndrome, the meconium itself is normal, but the intestine is functionally immature. And so what's happening is that the intestine can't get the meconium out. In Meconium ileus, the intestine would normally be able to get the meconium out, but the meconium is too thick to come out. Typically, Meconium plug syndrome affects the left side of the colon, and therefore is often commonly called small left colon syndrome, because when you look with your contrast enema, you'll see a small left side of the colon, but a normal colon elsewhere, or possibly macro. So this is associated with infants of diabetic mothers, as well as mothers who are on magnesium sulfate. So for instance, a mother with a history of preeclampsia, baby is born, fails to pass meconium, baby's got bowel obstruction, vomiting up bile. That would be a possible vignette for Meconium plug syndrome. So to differentiate this from Meconium ileus, when you do a contrast enema, the right colon should appear normal in Meconium plug syndrome or possibly dilated, whereas in Meconium ileus, the entire colon is micro and you're seeing those insipated pieces of meconium. You also want to differentiate this from Hirschsprung's disease, which we're not talking about here, but typically Hirschsprung's disease affects the rectosigmoidal area only. But if you really can't get the difference, especially if the Hirschsprung's disease is also affecting the descending colon, a rectal biopsy can provide a definitive rule out for Hirschsprung's. The treatment is the same as for Meconium ileus. You're getting a N-acetylcysteine enema that will help with the blockage, and the left colon will eventually develop. Okay, and here is Meconium plug syndrome. So note here that you've got a normal left colon and a slightly more dilated transverse and right colon. Here's another one. I think that's it.